Welcome, everyone. Here we are at office hours. We're happy to have you here with us today. Our guest today is Navaneeth Nair, who is the Chief Product Officer at Infinx. Welcome.
Thank you, Deb. Happy to be here.
Great, nice to have you. Let's talk about what is top of mind at every healthcare organization today. No matter what we're talking about, it's staffing shortages. But of a special concern is that the staffing shortages are affecting every single level of the organization, including patient access. And of course, that's part of the very important revenue generating section of any organization. Can you talk to us about prior authorization in this regard and how organizations can use automation to try to alleviate some of these challenges?
Yeah, sure. I think the first thing I think we should kind of peel away and understand is kind of work we do in the front office, right? I think when I think about the front office is two arms of the work that is essentially done. One is what I call is patient facing and improves the patient experience or relates to the patient experience, whether that is scheduling or getting an appointment or talking to the patient about their financial needs. But the front office are also saddled with significant amount of effort. I want to say, which I call it the back office of the front office, where they are trying to actually work with the payers, right? Whether that is eligibility verification, identifying what the estimates are, how much of their deductible has been paid, whether something needs prior authorization. And what we see with most of our customers is that when in the past they've always had a large enough staff to actually deal with both sides of it. They've had dedicated teams in some scenarios. Now with the latest kind of both the market and kind of the situation that we're faced with in terms of the staffing crisis, teams are having to choose how we balance these, right? And what we've realized is that the patient experience still needs the human touch. You are not going to be able to automate yourself out of it. I don't think most patients like hearing from a machine or a bot or something like that. Most of them get turned off by that notion, right? So you essentially need your staff to really focus on the patient and their patient experience. So what does that mean? That means you have to find a way to actually take the back office and automate as much of the back office. And the goal is to identify tools, technology, services that can essentially eliminate anything that is not patient facing in the front office, and do that using automation or other techniques of that nature. That's essentially, I think, what we're seeing with most of our really smart large customers really kind of focusing themselves and kind of going in that direction. And that's where I think automation kind of plays a critical role, because a lot of the payer related activity in some cases involve clinical activities, but in many cases they are mundane in the sense that you're going to a portal or finding some information. So automation is actually a very good candidate for actually resolving those kinds of tasks. So I would say focus on kind of the experience part. Don't try to introduce automation into that within patient access. But when you think about the payer, the financial clearance functions, prior authorization in particular, fairly heavy process in the back end, automation can really help with those processes.
I like that approach, because I think even people who work in hospitals for a long time, they have to continually remind themselves that the best day in a hospital is the worst day of a patient's life, because they don't want to be there, right?
Absolutely. Yeah. And I think that also impacts, I mean, if we just think about it from a pure customer metric perspective, right? If we think of our customers who are the hospital providers essentially being customer centric, it impacts the bottom line, because if a patient is not satisfied with the front office, that actually impacts as much as more than the service they get when they meet the physician.
That's right. That's right. That's that very first touch that either satisfies them and relaxes them that they're in the right place, or makes them think, if they can't get this paperwork right, how are they going to get my surgery right? So
Yeah.
yeah, yeah. So even though we're in 2023, a lot of healthcare organizations are still doing prior authorization manually, which is kind of hard to believe, I guess, in some quarters. Can you talk to us about what are the key challenges that result in people still doing this, and why it's so manually intensive?
Yeah, I think it's unfortunate to say, but I think the industry itself has created enough barriers around this process. The payers themselves. I want to start with the notion that if you want a process to be seamless, there needs to be limited friction in the interaction between kind of the providers and the payers, right? And over the last 20, 30 years, I think we have started to master the act of doing that when it comes to claims or remits being posted back or ERAs. But when it came to front office activity, it was always kind of, the payers always had this notion of, hey, there isn't a standard, you come to my solution to figure it out. Now, that works in most scenarios. If you're a small provider working with 4 or 5 payers, it works. But when you, in most of the providers, even the small offices that we work with, actually now have to deal with tens of different payers. And in the absence of a unique standard or uniform standard for prior authorization across the payers, every payer is actually trying to do their own approach to prior authorization, right? They kind of vary from, hey, we want you to only use our portal, to have you actually do it via fax, in some cases make phone calls. So that's one problem. There's no uniform standard associated with it. The other problem is, I mean, to some degree, from a payer perspective, they are, I mean, whether we like it or not, they are also trying to offload work. Because every time you pick up a phone, somebody has to pick up a phone on the other side. So they are trying to really offload that work by asking you to go to a portal. Now you have to remember how the portal works and the structure. But guess what? If you say, hey, I'm going to always call all my payers. If you look at some of the hold times just have continued to increase, right? It is not a pandemic phenomenon anymore. Post-pandemic, the hold times continue to increase with the payers. That's primarily because they are actually trying to shift work away, right? To some degree, they're saying the work needs to be done by the provider, right? So you've got a lack of standard situation here, and then payers are kind of offloading work. The way they offload work is, hey, work on this portal, send me this fax. That's kind of the other problem, right? The other thing with prior auth is that prior auth is challenged also because of the fact that it's one of those processes which actually needs clinical review in a financial process, right? So you're now actually introducing having to evaluate for medical necessity or clinical guidelines and be accurate with the information that you send, because you've got a clinical reviewer on the other side. And if you don't have all the information together, you are going to go into somewhat of an endless loop trying to actually solve for that. And when you go into that loop, guess what? The problem that I described, the lack of a uniform interface between the payer and the provider becomes even bigger, because in many cases, and we see this with all our customers, is that you are able to initiate an authorization on a portal, but if it dropped into some kind of a manual, you may have to call up and find from the nurse, why is it in manual? What review information do you need? So if you don't submit all the correct information, you could be in somewhat of a, either in a pended review or a peer review hell, as I call them, with respect to getting the authorization, right? So I think these are kind of, I would say, primary things that are impacting kind of prior authorization. I would say the last thing I would add is that these things were always existed, right? These are not new from a prior auth perspective, and these have always existed even from eligibility benefits perspective. But I think when you think about some of the other financial clearance functions like eligibility and benefits, we have started to see better adoption of the standards and things of that nature. We haven't seen that in prior auth at all. And more importantly, the other thing that I'm seeing over the last 5 years is payers have actually significantly ramped up the number of things that need authorization. So if this was an exceptional process where you were doing it on very high frequency, very low frequency, high cost procedures, then both the provider and the payer kind of has incentives to kind of do the work because there's a lot at stake for each other. But now we have actually made prior auth mandated for so many high frequency, low cost procedures also. It just adds to the burden for the provider at this point.
High frequency, low cost, like what?
I mean, if you look at a lot of the imaging that in the past, it may be some of the high tech imaging may have needed prior authorizations, but now they've gone down market. The same goes with specialty RX. Certain things that did not need prior authorizations in the past, now nearly, I think most of the specialty pharma needs an authorization of some kind or the other. So we are seeing that PT, OT is another classic example, usually wasn't something, home health is another. Areas that actually in most cases were not falling into significant utilization management reviews are actually now falling into prior authorization zones for many of the payers.
Of course, at the end of all of this is the patient waiting for care.
Absolutely, absolutely.
So,
and in the past, you may have waited for like if you're doing an expensive surgery, I can understand you go through the process. There's a lot of prep associated to it. But now, I mean, if you're trying to get an MRI just to know if you need a surgery, that MRI might not get through.
Right.
If the patient and the patient at that point is frustrated.
So, on the other hand, when automation is integrated, tell us about the other side of the coin. What happens when automation is appropriately adopted by a healthcare organization? What happens downstream?
Yeah, I think the biggest value proposition downstream, again, I think we have to recognize in a process like prior authorization, it's not perfectly automatable, right? It's difficult to say that, but as a technologist, I kind of cringe at the thought of how difficult it is to automate the authorization lifecycle compared to a lot of things. Right? And in today's world that we live in, where we can go on a website and buy anything from Etsy and it tells you can pay through Amazon or PayPal or anything. We are used to a commerce structure which is instant gratification, and as a technologist, I understand how it works in the back end, and I'm just frustrated that it doesn't exist for our business or healthcare, right? So, but when it's automated, I think what I would say is a lot of the manual processes that actually involve connecting to a payer, initiating an authorization, submitting demographic information, things of that nature, you should have a machine help you do it, right? It's an assisted automation model where the machine helps you with those tasks. I think the machines are still, I mean, we're working on some very early stage work when it comes to machine learning and AI related to clinical NLP, but machines are still not in a place where they are actually good at answering clinical questions or being accurate about clinical information. That's an area that still you will need a domain expert or somebody who understands the patient chart to kind of be part of the process. But I mean, the goal of automation in these processes is to limit as much of the interaction that is necessary from an expert, right? In that scenario, you want to limit them to just the clinical part of the process. And hopefully the rest of the process can be dealt with by the machine in some shape or form.
So that alone is a time saver and can improve
Absolutely.
Accuracy of we have finally connected and we can move on to the next step. Yeah,
and I think that, and yeah, it comes in both speed and accuracy or quality, as you said. We have seen that, and we have our own teams that do prior authorization. As you know, we have seen actually I would say cost reductions or time reductions of effort when we did time and motion studies associated to it to roughly 70 to 80%, where we can reduce the amount of effort when automation is applied correctly, right? But it, again, as you said, it has a very big quality impact because You won't believe how many times like the auth number from the portal was incorrectly transcribed over to the EMR, and we have a denial. We do a lot of ER work for some of our customers, and as we do some of these ER recovery and appeal, we realized that there was an authorization done, but the incorrect authorization numbers were provided, so you get an authorization denial, right? So it's not only the function of, hey, we can get speed with it, but it also it's consistency and accuracy with respect to the data that you're sending.
So 70 to 80% is a big number, and that leads us to talk about time, right? If delays are piling up because staff members are now doing multiple jobs, staff members who aren't correctly trained they've got piles on their desk. What can automation do to start to not only support staff, support the organizations, but start to reduce these pileups of denials that directly impact patient care?
Yeah, I think if the primary cause of denial, and we see this with many organizations, is that some of the largest denial groups that we see when we evaluate accounts receivable is primarily driven by the front office. Whether I like it or not, it's either eligibility or prior auth delay related. Coordination of benefits kind of comes a close third. So if you really think about it, if we can have automation actually play a critical role in these functions to perform them, then I would say the front office is not going to feel burdened about having to manage the patient experience while dealing with these issues, right? If you think about a traditional life cycle, if you have a patient information, if you have a patient or a new order come in, if you're able to quickly pass that order information, identify what procedures have to be performed, maybe it's a referral that came from a specialist or another provider, and you have that information quickly disambiguated into an order form in your system, that itself today kind of takes time. If it comes through fax, there are people actually having to manually label and tag it. Machines are really getting good at actually doing those tasks. Once you do that, once you identify the patient, their member information, what procedure is being performed, you can actually put through a system like Infinix or others, where it actually can immediately identify if the member has the right coverage. If that member has additional coverages, we see that all the time, where coordination of benefit denials come through because you didn't do a secondary benefit coverage identification. So you can do an identification, you can identify what their out-of-pocket is in most scenarios, mostly electronically. The entire process can be automated. And once you have that and you have the clinicals associated to the patient, you can actually submit it for prior authorization. So if you can have the machine help you identify, does this require prior authorization? So as you know, we kind of go through a 3-step process where we determine if auth is required or not. If auth is required, we are able to actually initiate the authorization. If auth is not required, and 60% of the times, actually, we see that auth is not required, but we don't know because the plan on a gross level doesn't give us any data, right? There, in most cases, payers are still very obtuse or obfuscated about which procedures for which plans need authorization. You really have to keep checking, and they keep changing the goalpost on those. And those goalposts may not just be their function. It could be that the employer decided to add that or not add that or carve out. So I can understand the issues, but it's still very, very, there's no transparency to the notion of determinations. We have built up technologies to actually help with understanding that, because if no auth is required, you can schedule the patient, which is what, I mean, every provider is trying to do, get them the services that they deserve. So I would say that that's the first step. If you determine authorization is required, hopefully you have automation actually initiate the authorization for you, and then ask for assistance where necessary, right? When if clinical documentations are not complete, or the machine detects that all data is not available to initiate authorization, that's where you may want to have the machine prompt and have somebody help them. But in most cases, it should happen seamlessly if the information is correct. And once it's initiated, the machine can also follow up. But now there is also limitations to it. At some point, we realize that when we follow up, and if the payer has spended it and has not come back with responses, payers are very stingy with providing actual reasons for why it's still pending. You end up having to call them to figure that out. But that's when, again, the human can come into play. But those should be exception scenarios. In most cases, we actually see that as long as we have submitted the right information, you can actually get the authorization. That also brings up kind of capabilities to actually understand what needs to be submitted. Right? So we have actually built kind of mechanics into our products where we keep the latest and greatest of all the payer guidelines available at fingertips. So a physician or a patient access team member can very quickly, for a given CPT or diagnosis code combination, know what guidelines exist. They can quickly scan their document and actually make sure that the document covers all the medical necessity conditions in the document so that it can be approved instantaneously. In other cases, on our roadmap, what we're building is essentially having the machine even do that, right? We're seeing AI take a big leap, and clinical NLP is actually making a lot of progress. We believe that in the next year or so, we will have the ability for the machine to evaluate if clinicals are all complete or not. But then you can bring in the human to actually supplement where you don't have that clinicals and actually have them supported. So I would say in the front office, I think automation should play a really good support or assistant role, right? So they should be the patient access team's best assistant, doing all the grunt work and calling for help when necessary, so to speak.
Right. And who doesn't want someone to help you with all the grunt work, right?
Yeah, we all want an assistant before Elon comes up with the bot, right? So
absolutely. I want to ask you a couple more questions, but before I do, I want to remind those attending today that if you have questions, please write them into the chat. So you were just talking about a lot of the fine junctures where automation can make sure that things are accurate, make sure that things are complete. And, you know, years ago, when they changed all the ICD codes, that was a huge mess for a lot of people who didn't have time to retrain staff and things were a mess. I would imagine that if you have automation in place and we reach another point like that where things are just turned upside down, that the automation would be able to help to avoid a lot of inaccuracy.
Absolutely, and the training part applies even today, and those listening and those who actually live in the trenches know that if you lose a person on the patient access side that deals with United or Optum, that's information lost because there is a way to work the Optum portal, there is a way to work EviCore. I was recently talking to a provider, and they were asking me, they were just wondering, wait a minute, we try this authorization with 3 diagnosis codes, and it says, hey, we need clinical information. But if only 2 of the diagnosis codes were provided, it says, okay, you're approved for this. Like, what is the reason? So there is a lot of tribal knowledge that gets built into people. One of the things we are trying to do, so we're trying to apply the machine to actually learn that, right? So the 2 things that we are kind of actively working. One is kind of normalize all the portals. So the way we are working is we want the input and the output necessary to be uniform within our product. And most of our customers will not expose them to the actual portal itself. The machine actually works the portals in the background. So what that means is a new staff coming on board doesn't have to suddenly now learn how EviCore does things, or how AIM does things, or how new BCBS New Jersey does something very specific. Because what we've done is we have trained the machine to do it. And the interface to the human is normalized to be one kind of way to do this, right? Hey, I'm looking for this one piece of information that I'm missing. Can you please provide me that? And you provide that, and boom, you're on, right? So the mechanics actually change. You don't have to now have people who train on all of these different things. Second thing is we're also training the machine to actually learn on these patterns, right? What are the patterns of questions we get, right? If we can get and understand the pattern of questions we can get, we can actually pre-process it and provide it to the patient access team member saying, hey, here is a transaction that I think has procedures that might need, or an order or an appointment that needs prior authorization. We believe it needs prior authorization. And we have looked at the procedures, and we believe based on what we see in the procedures and the diagnostics codes, you may want to get answers to these questions, because this is what will be asked by the payer. So we are trying to actually help the patient access team pre-process that information. So once that information is available, then you actually let the machine do the work, and you don't have to get in the middle of it. So those are some of the things that you can do to actually kind of solve for this kind of loss of knowledge. And the loss of knowledge is real.
So we have a couple of questions from attendees that I want to get to. The first one goes to AI. And is AI actually what you are using as you are talking about developing the technology and the automation? Is that the foundation of it?
Yeah, I think there are two things that are foundation. I mean, I always think of this as a closed loop of three things, or a three-legged stool. And I use the word AI a little differently. I think of AI as augmented intelligence rather than artificial intelligence, right? So if I think about kind of the Tesla car saying, "Hey, I'm going to ride you myself," and I don't think in healthcare we are there where we want to ride ourselves in the car. To be honest, the car itself is not ready, to be honest. So when you think about the reason augmented is because it's assisted by humans, right? So the foundation of what we do is assume a human is a critical component when experts are necessary, but apply AI when you want to make things more predictive and prescriptive. So assist the human with respect to, because AI is really good at learning from large scale data and patterns that humans over time learn through tribal knowledge, but AI is very good at learning that very quickly. So it can actually then assist you with it. So think of it making things more predictive and prescriptive. And then the third leg of the stool is automation, which is essentially just mechanics of being able to do the repetitive grunt work time and again, accurately, consistently, without kind of making a mistake, right? So it's a combination of all three. So think of the human being in the center, the expert, but then being wrapped from a platform perspective with both AI capabilities and automation capabilities.
So for organizations that are considering automation, I think a lot of thinking that we do in healthcare is the chicken and the egg, right? So if they're looking at their situation now and it's manual and they want automation, they may be worried that automation is going to take a long time to integrate and it's going to disrupt everything that currently exists. Can you speak to that in terms of time frame and ease of integration?
Yeah, I think at that point you have to use automation for integration also, to be honest. So you kind of make the chicken give you eggs. So to start with, to use the chicken and egg analogy. But the way I kind of think about that is, we've done this with a lot of different platforms. Many of the platforms, we kind of see platforms in two categories. There are some of the leaders in the market like Epic and the Cerners that have much more open integration capabilities. We have direct partnerships with them or integration with them. Then there is the other class of systems that actually they have internal integration capabilities like HL7, things of that nature. What we've done is we've built the ability to do prior authorization or patient access functions. So we have built the ability for them to very seamlessly integrate with our lifecycle within our platform. We've even actually gone to the scenarios where certain you'd not believe certain systems were so antiquated they could not provide any integration capabilities. And again, going back to the use automation for integration, we actually built automation where we had bots actually logging into these as if they're humans, picking up the cases that they want prior auth and pushing it to our platform, right? So we have multiple mechanisms of being able to make this as seamless as possible within the lifecycle. Our goal is essentially, if this is not seamless within the patient access lifecycle that already sits in a scheduling system or an EMR, it will not work. Because I think the problem is the last thing the front office needs is yet another system that they have to go monitor and manage and deal with, right? So if this doesn't work kind of in unison with the existing system, it would not work very
Well,
well.
thank you. We've reached the end of our time. I think this has been a great discussion and an important one, talking about how we still need human beings and we need automation to integrate technology.
Yeah, I think we still need human beings. We're always going to need them. I think what we need to do is preserve their critical domain expertise to manage our experience with our patients and make clinical decisions as necessary and let automation deal with the rest.
Absolutely. Well, thank you so much for your insights today. I appreciate your time. We've been talking with Navaneeth Nair. He is the Chief Product Officer at Infinx. Thank you very much.